This study evaluated the validity of the modified blood dye test (MBDT) for the diagnosis of dysphagia in critically ill tracheotomized patients with the aim of preventing aspiration pneumonia. Using FES as a reference, 41 patients were evaluated. The MBDT showed a sensitivity of 0.79, a specificity of 0.91, and an AUC of 0.85. Dysphagia was detected in 80.7% of cases with MBDT versus 70.7% with FES. The authors conclude that the MBDT is a useful tool for detecting dysphagia in this population, although it should be used with caution as a screen test.
In the introduction of the article, the importance of diagnosing dysphagia in critically ill patients with tracheostomy is addressed, given that this condition can increase the risk of aspiration pneumonia, reduce the effectiveness of swallowing, and compromise airway protection. The main objective of the study is to evaluate the validity of the modified blood dye test, this is MBD, as a diagnostic tool for detecting dysphagia in these patients. It is mentioned that allowed fiber optic endoscopic evaluation of swallowing, this is FES, is the most commonly used method for this type of diagnosis. The MBD could offer a less invasive alternative. However, its validity of diagnosing dysphagia in tracheotomized patients remains uncertain at this time. The study consisted of a case series conducted in the intensive care unit of a university hospital over a 2-year period. The participants were patients over 18 years old who had a tracheostomy and were in the process of weaning from mechanical ventilation. All patients were consecutively selected to assess their dysphagia status using the modified blood dye test. Patients with neuromuscular or neurovascular disease were excluded. All participants had the necessary cognitive capacity to perform the test and the ability to tolerate different texture in the mouth. In the procedures, the MBDT was performed first, followed by the FES between 6 and 24 hours later to verify the validity of the MBDT. First, the patient is placed in semi-seated position. Secretions are suctioned and the tracheostomy cuff is deflated. The MBDT is performed using liquid or pureed consistency, a mixture of 3 milliliters of water and 2 milliliters of methylene blue is prepared and administered to the mid-posterior third of the tongue, and the patient is asked to swallow. The following things were recorded. early and delayed cooing with voice, choking, oxygen desaturation, and blue stain secretion through the tracheostomy cannula. If no cooing or secretion were observed, the tracheostomy was suctioned again. The test considered positive if blue stained secretion are obtained through the cannula. The fees was performed using the same 5 milliliters of water mixed with methylene blue, administered to the mid posterior third to the tongue. The laryngoscopy was inserted through the nasal passage until the laryngeal vestibule could be visualized. And the Rosenbeck penetration aspiration scale was used for assessment.
Data analysis. Descriptive statistics were used to characterize the patients and endoscopic findings. The prevalence of dysphagia was calculated using FES as the reference method. For the MBDT, sensitivity, specificity, predictive values, positive and negative, and likelihood ratios were determined. The area under the ROC curve was also calculated with 95% confidence intervals. Data were organized in spreadsheets and analyzed using SPSS version 12. Evaluators worked independently and were blinded to each other assessment. Any discrepancies were resolved by majority decision, as there were always 3 raters involved. Ethical considerations. The study was approved by the Hospital Ethics Committee, and informed consent was obtained from each patient or their relatives. All data were anonymized and no patient images were used without explicit permission.
A total of 41 patients were included with a mean age of 61 years, of which 70.7% were diagnosed with dysphagia according to the FES evaluation. The MBDT diagnosed dysphagia in 74 patients, corresponding to 80.7%. This indicates that the MBDT showed good performance in identifying dysphagia. The MBDT showed a sensitivity of 79%, which means it was effective in identifying case of dysphagia in most patients who truly had the condition. The specificity was 91%, indicating that the test was also effective in correctly identifying those who did not have dysphagia. The positive predictive value of the MBDT was 95%, meaning that when the test was positive, there was a high probability that the patient truly had dysphagia. The negative predictive value was 64%, suggesting that not all patients without dysphagia were correctly identified. There were 23 true positive, 1 false positive, 11 true negative, and 6 false negatives, resulting in a false negative rate of 20.7% in the detection of aspiration. These results indicate that the MBDT is useful for accurately identifying patients with dysphagia.
The modified blue dye test may be useful in the diagnosis of dysphagia in critically tracheotomized patients on mechanical ventilation due to its high positive predict value. Its use may reduce the need for invasive testing and decrease the risk of bronchopulmonary aspiration. However, a negative result does not rule out dysphagia and should be interpreted with caution. The initiation of oral feeding in critically patients is a delicate process, balancing safety with the emotional well-being of the patient. Inadequate feeding can lead to pulmonary aspiration, infection, and increase the mortality. Many hospitals use clinical rather than instrumental methods due to practical limitation, and MBDT is one of the most commonly used tools. Although originally intended as a screening test, its low sensitivity for silent aspiration has limited its exclusive use for this purpose. Some studies report variable sensitivity, and although some show high specificity, others have questioned its reliability in detecting aspiration, particularly in mechanical ventilation patients. Several studies have compared MBDT with endoscopy, FES, and conclude that the latter remains essential, particularly before initiating oral feeding. Some reports suggest that MBDT may be useful as a complementary tool to avoid invasive procedures, but should not replace them completely. The results of trials vary greatly depending on the protocol used, the number of test repetitions, and the condition of the patients. The study has several limitations. The medical use of methylene blue remains controversial, with the FDA restricting certain formulations due to adverse effects, particularly in patients with gastrointestinal disorders. Although it is not banned in Europe, the literature is mixed. In addition, the clinical impact of each type of aspiration is not well defined. If the test poses no risk to patient morbidity and mortality, it could be used more confidently as a screening tool. To minimize confusion due to residual dye between tests, the tests were performed 6 to 24 hours apart. However, the possibility that this interval influenced the result cannot be excluded. Finally, although this study has one of the largest sample size today for this population, it is still small and has wide confidence intervals. Based on the results obtained, the authors recommend the use of the MBDT as a useful tool to confirm the presence of dysphagia in critically ill tracheotomized patients. This could reduce the routine use of instrumental tests, particularly in contexts such as the COVID-19 pandemic, where aerosol-generating producers such as FES were avoided. However, in the case of a negative MBDT result, FES should be performed to reliably rule out dysphagia.
The study recommends the use of the MBDT as a practical diagnostic method for detecting dysphagia, but emphasizes the importance of complementing with tests with fiber optic endoscopic evaluation of swallowing. In case where the MBDT yields negative results, this is crucial to ensure accurate identification of dysphagia. Moreover, the MBDT can be particularly valuable in critical contexts such as during the COVID-19 pandemic, where invasive aerosol generating procedures like FISH should be minimized. In summary, although the MBDT is a promising tool, it is essential to use it in combination with other assessments to ensure an accurate diagnostic in critical in patients with tracheostomy.